All right, it's so nice to be here. Norma Jo stole my line about LARC not being for everyone, but we'll get to that in a second. I apologize that I forgot my cape. I should have known that I should bring one. Oh, sure, why not? I was feeling a little drab, so this will be exciting. My talk initially wasn't going to be as personal as Jody's was about kind of my life story, but I'll just briefly, since Norma Jo asked me to talk about that, I'll just tell you that I came to the, thank you, now I'm ready. I came to the UCSF residency program back in 2002, and I was lucky enough that it was when I was a third-year resident, was the first year we had integrated abortion training and family medicine at my program. And it was really one of the first programs that really took that on, and it was an amazing experience, and that was how I did my residency research project on the process of integrating abortion training into family medicine residency programs, both looking at resident experiences and programs around the country that had done it, and in residency program director experiences in doing that. Did 2 qualitative papers that were published in Family Medicine. Based on that, that is how I first met Jody. I randomly sent her a draft and said, will you look at this? And next thing I knew, we were off and running, and our collaboration has not stopped since. So it was a huge opportunity, and it just really set me on this life course, and I'm so happy that I'm doing this. And I'll also say that I did a fellowship in family planning with Jody at UCSF, and so family medicine obviously does full spectrum comprehensive reproductive health care, but also doing abortion-related and family planning-related research in academic practice is also definitely an option. So thanks so much for having me. My particular area of research focuses on health equity in family planning and also patient-centeredness in family planning. So I'm excited to be here to talk about my work and the work of others to kind of understand how we can apply the patient-centered frame into family planning work.
There's a little delay.
Okay, thank you for the, don't think that long a delay though.
There's the right.
Yeah, that one?
Yeah.
All right, I might need some IT support. Am I supposed to point it anywhere?
I wouldn't.
Let's try backward, see if that does anything. Okay, so if you can come up and help me, I'll just kind of get started. So I'm going to talk about, just give you some breakdown about what I mean when I talk about patient-centered care and how to apply it to family planning. And then I'm going to talk about some issues related to healthcare disparities and how patient-centeredness interacts in family planning with healthcare disparities, and talk a little bit specifically about shared decision-making. So to get started, I'm sure you all have been exposed to the general concept of patient-centered care, but I want to make sure we're all on the same page when I say patient-centered care. And also I'm going to spend a little bit of time drilling down on how the application of patient-centered care is a little different in family planning than it is in some other areas, like specifically primary care areas where, like diabetes and hypertension management. So patient-centered care it got more attention in 2001 when the Institute of Medicine published its Crossing the Quality Chasm report. And that was when it described patient-centeredness as one of the 6 domains of quality that it thought was important to pay attention to. And in that report, it defined patient-centered care as care that is respectful of and responsive to individual patient preferences, needs, and values, and ensures that patient values guides all clinical decisions. So since then, shockingly, only since 2001, the concept of patient-centered care has gotten a hugely increased amount of attention, and a lot more literature and research investigating this. And this is driven by 2 factors. One is the kind of obvious, seemingly fact that what the medical system should be designed to do is to meet the needs of patients, right? It shouldn't be designed to meet public health needs. It shouldn't be designed to meet the needs of doctors to maybe get home or to get to the next golf game or whatever it might be. It should be designed to meet the needs of patients. And many people, when you talk about patient-centered care, say to me, like, well, isn't that obvious? Isn't that what we should always be doing? And I always use the analogy of when I was in med school in the 90s, that was when evidence-based medicine kind of really was the first time that term had been used. And I remember my father, who's not a physician, no one in my family was, he's a banker, just looked at me and said, well, what are you doing before? Like, how is that even something that needs to be said? And I feel like it's very much the same with patient-centered care, but the reality is, just like with evidence-based medicine, we know that most of what we do is in fact not that evidence-based. And just like that, most of what we do is actually not that patient-centered. And that's why we really need to keep our eye on the ball and remember this may seem obvious, but often that's not actually what's happening. The other reason, in addition to this ethical component of why it's important to pay attention to patient-centered care, is the fact that we do know, as well from studies that have been done, again, in the past few decades, that when we pay attention to what patients care about, they actually do better with respect to the hard clinical outcomes that the healthcare system and the public health system often cares about. So, for example, a non-patient-centered outcome that's often talked about is hemoglobin A1C, right? We care a lot about hemoglobin A1C when we're taking care of patients with diabetes. Do patients? Sometimes they do if we've done a good job of educating them, but at the end of the day, it wasn't the most patient-centered metric. So people, including people at our institution, have developed a concept called diabetes-related quality of life, which integrates not just whether or not somebody has good blood sugar control, but also whether they have too much medication burden, whether they have side effects from medications, whether or not they can afford their medications, whether or not they're having hypoglycemic episodes. So again, it's about taking into account the full range of things that actually affects how a patient thinks about their experience with healthcare. And we know when we do that, it improves even hemoglobin A1C, because patients who have higher diabetes-related quality of life are going to be, for example, more adherent to their medications. Okay, so that's the rationale for patient-centered care in general. I'm going to be focusing specifically on patient-centered communication, which is one critical aspect of patient-centered care. And that's because when we do a good job of talking to patients, we can elicit what their values and preferences are, and we can respond appropriately to what their values and preferences are. And we know from literature in the general medical health communication literature that interpersonal communication actually makes a difference, despite the fact that we increasingly have so little time with our patients. So studies have found that interpersonal communication influences use of medication, use of preventive services, and adherence to medication. And all of these are clearly relevant to the family planning context. That picture is a picture of my residency director, Teresa Viela, when I was a resident. It was published in the San Francisco Chronicle, and I just feel like it summarizes warmth and love in a clinical encounter. Yeah, it's so her. Okay, so in family planning specifically, we know that interpersonal communication has an impact as well. So studies, for example, have found that what methods providers talk about and how they talk about them to their patients influences what methods people choose. In addition, we know from literature that the quality of interpersonal communication, how patient-centered the communication is, influences women's use of contraception. And one study that we just published last year in the American Journal of OBGYN was longitudinal, and we found looking at both audio recording measures of contraceptive counseling, we recorded 342 contraceptive counseling visits, and also patient report of how patient-centered the contraceptive counseling was associated with contraceptive continuation. So this tells you that patient-centered communication has an impact on people's ability to choose a method that's a good fit for them. But it's also essential to remember that it's not just about those clinical outcomes, right? It's not just about getting patient on a good method. It's about letting them have a good experience with the healthcare system. This is consistent with the triple aim that's increasingly talked about in terms of the qualities of a high-functioning healthcare system. Patient experience of care is an ethical issue that we should be engaging with regardless of its impact on patient outcomes. Okay, so what do we know about contraceptive counseling specifically? Well, we know that in general, as Norma Jo already alluded to, there's an increasing movement in our field over the past decade in family planning, but also in primary care and other settings, on promotion and emphasis on long-acting reversible contraceptive methods, specifically IUDs and implants, which are the most highly effective methods. And these are long-acting, provider-controlled methods. You need to have a provider put them in, and for the most part, you need to have providers take them out as well. And so the literature, though, has really focused on how these are like the best methods. There's a study done, or a paper that was written in 2005, for example, that said LARC, or IUDs, the pendulum swings back. So this idea that there had been this distaste for IUDs after the Dalkon Shield, and now we were going back the other direction towards enthusiasm. And this has been manifested in the counseling interaction specifically around counseling models that have really encouraged providers to emphasize and promote these methods, like I said. So an example is what's called a tiered effectiveness model of counseling, which is where you use a chart that's structured by effectiveness of methods, and you really emphasize the fact that these methods are the most effective, that they're the best methods, the one at the top, which are IUD and implants. Even though sterilization is also at the top on that chart, usually that's kind of left off because providers often have a bias against that method. And so that was actually the method of counseling that was used in the CHOICE study, which some of you may have heard of in St. Louis. Although that being said, I always want to emphasize with that the study that was done looking at the counseling in the CHOICE project found that it wasn't the counseling that had an impact on actually uptake of IUDs and implants in that study. It was just the fact that they were made freely available. Another directive counseling approach that has been used in the literature is motivational interviewing. I'm sure many of you, if not all of you, have been exposed to motivational interviewing at some point. And what motivational interviewing is, it's a directive approach to counseling designed to elicit patients' own motivations to achieve a desired behavior change. And as I'm sure you know, it was developed in the context of addictions. That was how it was developed, was to help people to identify their own motivation, resolve their own ambivalence towards why they might want to stop using drugs, stop smoking, stop drinking. So this has been applied in a broad range of fields, but in family planning, it's been applied in the concept of helping patients resolve their ambivalence towards LARC methods. And as you'll hear in a second, I don't think that's a great fit. I don't think LARC methods and smoking are two things that we really should, or not smoking are two things we should be equating. But just so you know, this is kind of the general landscape right now of what's going on in contraceptive counseling. And so LARC first is kind of the mantra of people who believe in tiered effectiveness counseling, and that's some patient materials that we have available. So for those of you who are in the clinical sphere already or have been for a long time, you've probably seen this shift towards directive counseling and contraception in action. So personally at San Francisco General Hospital, where I work, we've definitely seen this philosophy or this practice of residents coming up to us and saying, oh, I'm sorry, she's going to use the pill. Like it reflects badly on them and the care they provided that she's going to use the pill. I mean, don't even get me started if she's going to use condoms. That's just like people think that they clearly provided horrible care and that I'm going to judge them, that somehow that that's going to reflect badly on my assessment of them as clinicians. We also see it in references by professional organizations. Both the American Academy of Pediatrics and ACOG have released statements on LARC methods that have talked about them as first-line methods. And in some ways, that is motivated, that use of the first-line language is motivated by the idea that these are methods that are underutilized, and we need to kind of make clear that these are methods that there shouldn't be any limitations placed upon them. But in how this has been interpreted is that they're better methods, not that they're first line along with other methods, but that they're the best methods themselves. And we've also seen performance evaluation metrics in some settings that have been based on whether or not a patient chooses LARC. So it's not just the resident thinking that I'm going to judge them by the fact that their patient isn't using LARC, but it's actually sometimes patients or providers are being judged by what proportion of their patients are using LARC. So how do we understand this directive counseling movement from a patient-centered perspective? Well, to think about that, we have to think critically about what kind of decision contraceptive choice is. So in decisions in which there is one approach or two approaches that are better and that we know lead to better health, objective health outcomes, there is a place for patient-centered directive counseling in which the provider uses counseling to encourage choice of or adherence to a specific management option while still engaging with patient values and preferences. So performs patient-centered directive counseling. And that was really the whole idea behind motivational interviewing. We have an idea from evidence that it's better if a patient isn't using heroin. So we, therefore, try to talk to them to get them to use, we have an agenda, we try to get them to stop using heroin, but we engage with their own values and preferences and experiences in that process. In contrast, there are decisions which are considered preference sensitive. So these are decisions in which there is no one best option and which the best choice depends on the patient's values and preferences. And in those types of decisions, the provider's role is to provide decision support, to support the decision-making process, but not to direct it, with the goal of helping the patient choose the option that is the best fit for their own values and preferences. And so kind of iconic examples of this are early breast cancer treatment or early prostate cancer treatment. So what kind of decision is contraceptive choice? Well, we have a vast amount of literature that patients have strong preferences for what kind of characteristics their method will have. For example, menstrual side effects, how often they take it, whether they can discontinue it, return to fertility, whether they can discontinue it on their own, specifically without provider engagement. And this relates to their, personal preferences. Is spotting going to be the end of the world for them? Do they want to have a regular period? And importantly, with respect to effectiveness, how they feel about effectiveness, it relates to how they view the potential outcome of a method failure, which would be an unplanned or an unintended pregnancy. So I'm going to dig into that for a little bit. So how do women think about pregnancy? So the unintended framework, which is really kind of how we've talked about pregnancy for decades, boils down to the idea of intentions and plans being kind of the be-all and end-all of how we judge whether a pregnancy is quote-unquote good, okay? And a pregnancy intention means timing-based ideas about if and when to get pregnant, and plans are actual actions that you take to act on those intentions. Well, we know from literature that has been increasing over the past decade that how women think about potential future pregnancies does not only boil down to intentions and plans. And there are other dimensions and factors that play into how women think about potential pregnancy. And these include, for example, desires, which is their strength of their inclination to get pregnant or to avoid pregnancy, and their feelings, which are their emotional orientations towards pregnancy. So on some level, you can say, okay, that's fine, but they're all gonna line up, right? A woman who has a negative emotional orientation towards pregnancy is not gonna be planning a pregnancy. So it all is gonna kind of come out in the wash anyway, and we can just focus on intention. Well, what the literature has shown us is in fact that that's not true, and that these are all distinct concepts, that different ones have different meaning and meaningfulness to different women and different individuals, and that they can actually appear to us as outsiders, trying to look objectively, is inconsistent with each other. So to give you a sense of some of the literature that's fleshed this out, these are some quotes from qualitative studies done by my colleagues around the country that have tried to drill down on how women themselves, from a patient-centered perspective, understand the concept of potential pregnancy in their lives. So this was a study done by a colleague of mine in Wisconsin, which was looking at how women think about IUDs and why they might not want to use them. And one of her participants really summed up what she was hearing by saying, I guess one of the reasons that I haven't gotten IUD yet is I don't know. Having one kid already and being in a long-term committed relationship, it takes the element of surprise out of when we would have our next kid, which I kind of want. I'm in that weird position. I just don't want to put too much thought and planning into when I have my next kid. So for her, planning and intention is not that meaningful. Other research has looked at the concept of the relationship between intention and emotional reactions to pregnancy. And this research done by my colleague Abigail Aiken in Texas included these two quotes. One is, another pregnancy is definitely not the right path for me, and I'm being very careful with birth control. But if I somehow ended up pregnant, would I embrace it and think it's for the best? Absolutely. And I don't want more kids and was hoping to get my tubes tied. We can't afford another one. But if it happened, I'd still be happy. I'd be really excited. We'd rise to the occasion. Nothing would really change. And then another aspect of this is the desires piece, that having an intention to have or to avoid a pregnancy doesn't necessarily tell you how strongly somebody desires or does not desire a pregnancy. So just to give you one illustrative quote, I already got a kid, so I know I'm not opposed to having children. But if it happens, it happens. I'd prefer we don't have children right now, but if it happens, okay. And this has kind of conventionally been called ambivalent, and this idea about we need to resolve people's ambivalence when they feel this way. And I want to problematize that a little bit, because this is how women feel. Should we have an agenda about whether or not they are allowed to be ambivalent or not? So to get into that a little bit, one of the reactions that I hear when I talk about this issue and when my colleagues talk about this issue is, shouldn't we get women to plan for their own good? Isn't there good literature that a good pregnancy is a planned pregnancy? And so therefore, we should be doing what we can to get patients to yes. Whether it's planning or not planning, we should get them to one pole or another. And the reality is that there is very little literature to support the universal negative aspects of having an unintended pregnancy. Most studies show actually no association with social or health outcomes. There are a few studies that show some associations with short-term outcomes, like low birth weight or preterm birth, but these are very small effects. And they're mostly retrospective studies that ask women after the fact about whether or not the pregnancy was planned, which are just incredibly flawed, because if you have a bad pregnancy outcome, you're gonna be much more likely to remember, oh yeah, that one wasn't intended. And it's important to to think about the fact that really, based on the quotes and the kind of concepts I just presented, this is not that surprising that we don't have good data that all unintended pregnancies are bad, because we know that unintended pregnancy can mean very different things to different women. For some women, it's going to be the end of the world, and for some women, it might be a happy accident, and there's lots of room in between. So when we lump all unintended pregnancies together, it's not going to show something universally bad because it means different things to different women. So putting that together around contraceptive counseling, what that means is that effectiveness of a method is not going to have the same meaning to all women, because the meaning of an unintended pregnancy is going to mean a different thing to all women, to different women. And therefore, how it relates to other preferences around things like frequency of taking it and menstrual side effects is going to vary. So therefore, contraceptive choice is a preference-sensitive decision. It's a long lead-in to that conclusion, but that was my point. Contraceptive choice is a preference-sensitive decision. So therefore, this directive counseling is problematic, both from the perspective of not honoring women's autonomy, which is incredibly important, but also because it ignores this preference-sensitive nature of contraceptive choice. In addition, I don't have a ton of time, but I'll just say we also know from a public health perspective that pressure to use specific methods can be counterproductive. Studies have shown that it's in fact associated with method dissatisfaction and discontinuation. So we need to be aware of that as well. Okay, so research that I've done and others have done have suggested that instead of directive counseling, shared decision-making is a really important and valuable model for contraceptive counseling. Shared decision-making is often misunderstood as kind of just good counseling that you apply across the board. And in fact, it's a very specific approach to counseling that is used in preference-sensitive decisions to help patients weigh their values and preferences and to facilitate them being able to make a choice that is consistent with their values and preferences. I'll just read the last part of this quote was, "It's a process that provides patients with the support they need to make the best individualized care decisions." So it's about bringing in evidence, for example, around effectiveness and side effects, aligning those with patient preferences to allow people to make a good decision. And briefly, I'll just say that qualitative and quantitative research that I've done has found that, in fact, when you ask women what they want from contraceptive counseling, they don't say, "I really want providers to tell me about LARCs first and foremost," and really emphasize that. They say, "I want providers to help me choose a method that's a good fit for my preferences." No surprise, but it's good to have it documented. Okay, so I really want to spend a few minutes on shared decision-making and disparities in family planning care. So as I'm sure and I hope most of you are aware, there's a tragic and painful history in this country and pretty much every other country in the world of reproductive injustices in which certain people's fertility has been devalued, and that's along dimensions of oppression that occur in any given society. So in the United States, specifically women of color and poor women have experienced injustices that have actually been enacted through the family planning care delivery system. So for example, non-consensual sterilization that has happened throughout the 1900s and even into this last decade in the California penal system, non-consensual sterilizations were carried out in the last few years. It was found out about 5 years ago. Other examples of reproductive injustices include unethical testing of oral contraceptives in Puerto Rico, people having welfare benefits dependent on whether or not they're using long-acting reversible contraception, targeted marketing of Depo. And this is all part of a history of stratified reproduction in the United States in which certain people's reproduction is valued and other people's reproduction is devalued, and therefore attempts are made to limit it. So in the family planning delivery system, this is not surprisingly manifested in that women of color have a documented distrust in family planning providers in terms of the extent to which they are prioritizing their value, the providers are prioritizing their patients' values and preferences. So for example, in one study, 1/3 of black women reported that medical and public health institutions use poor and minority women as guinea pigs to try out new birth control method. Greater than 40% of blacks and Latinas, and this was the studies of 18 to 29-year-olds, so young women in the past few years, think government promotes birth control to limit minorities, and black women are more likely to prefer a method over which they have control, which is a clear echo of this history. And while we think this is all potentially part of this historical context in which family planning is delivered, in which there's this history of reproductive injustices, we know, in fact, from literature in general about how women or people of color are treated by our healthcare system, is that people are treated differently depending on their race, ethnicity, even when everything is held constant by the medical system and by healthcare providers specifically. And another report by the Institute of Medicine documented this in 2002 called Unequal Treatment, and they stated biases may exist, often unconsciously, among people who strongly endorse egalitarian principles and truly believe that they're not prejudiced. There's considerable empirical evidence that even well-intentioned whites who do not demonstrate that they're prejudiced demonstrate unconscious, implicit, negative, racist attitudes and stereotypes which significantly shape interpersonal interactions. Evidence suggests that bias, prejudice, and stereotyping on the part of healthcare providers may contribute to differences in care. In the family planning context, research that has looked at this has found, in fact, that women of color feel that they are treated differently by the healthcare system. So low-income women of color are more likely to report being advised to limit their childbearing than are white women. Blacks are more likely than whites to report being pressured by a clinician to use contraception, and 2/3 of Black women report race-based discrimination when receiving family planning care. To me, these perceptions of discrimination matter, whether or not we can document that they're actually, that their experiences are, in fact, differential. But the reality is that we've also documented that they are differential. So, for example, a study done by a colleague of Jody's and mine, Andrea Jackson, found that family planning providers have lower levels of trust in their Black patients. And this makes sense in the context that other studies have been done that have found that providers are more likely to recommend provider-controlled methods for women of color. So a study done in the 80s found that providers are more likely to agree to sterilize women of color and poor women than white women and women with more money. And Jody and I did a study when I was a family planning fellow, and we looked at disparities in counseling about the IUD and used standardized patients to ask providers whether they would recommend an IUD to a specific patient. It was all standardized, other than their race, ethnicity. And what we found is that low-income Blacks and Latinas were more likely to have the IUD recommended than were white patients, with absolutely everything else held constant. So what this tells us is that there's both a historical context of reproductive injustice by race, ethnicity in the United States, and there's documented disparities in counseling that are both impacting the quality of care women are receiving and impacting their trust in the healthcare system. And so it is essential that family planning providers, while we have to do this with all patients, regardless of race, ethnicity, it ups the ante that we focus on provider preferences when we're caring for populations that have been impacted by this history and by these ongoing healthcare disparities. And so we need to explicitly focusing on preferences, and shared decision-making in which we focus explicitly on patient values and preferences provides us an opportunity to do that, to make it clear to patients that we're focusing on patient preferences while avoiding the temptation to kind of veer too far to the other side, where we just kind of say, here's the information, and we don't provide any support for patients because we're so afraid of appearing coercive, which is not quality patient care either. So I don't have time really to go into the process of shared decision-making, but I'll just say, starting with an explicit focus on patient preferences in which you ask, what do you care about in a method? Instead of saying, what method do you want? Because patients will think they're supposed to give you an answer if you say that. But what is important to you about your method makes it clear that that's what you care about. Not starting by, have you heard about these great IUDs and implants? What do you care about in a method? And then going on to elicit their preferences for method characteristics, and then providing scaffolding for their decision-making in which you provide information based on what they tell you matters to them, and then you help them align those preferences with what you know about the methods that are available. So thank you very much. It's a pleasure to be here, and sorry I had to rush through the last few bits.